All right, let's talk about ECMOs. And this is some of the basic equipment that you can see. This is an ECMO, or it's an extracorporeal membrane oxygenation. It's a life support system, helps people with severe heart or lung problems by temporarily taking over those functions or organs. Okay, so ECMO itself, and we're going to talk about the past to learn about the future. ECMO itself really was put on a shelf. It was not as, so this is basically a heart and lung machine that's been kind of tweaked, all right? And the technology came out in the 60s, and there's two pathways. You have your pediatric and you have your adults. Adults, it didn't really work well. It didn't really work well until 2009 when the N1H1 came out. What N1H1 was very interesting is that it attacked young people and attacked the lungs only. And we'll talk about how ECMO, what it does. Over here, and the other group was, you had adults and you had children. Children have done amazing on ECMO because when you think about it, is they usually just have one insult to the lungs, and we can get them through this and they can recover and they do well. Adults are different because I don't want you to think of ECMO as a panacea. ECMO does not cure cancer. It does not fix the heart, okay? It can temporarily get this patient through a period until their heart can recover, but it is not a heart transplant, all right? It does not transplant their heart. It does not transplant their lungs. It does not transplant their liver. It does not filter out malignancy and does not cure malignancy. What it does, it's a bridge, okay? It's a good bridge, and the purpose of this bridge is to take stress off the lungs, to take stress off the heart, and see if these organs can recover. So look how big, we're gonna see right here, see this cannula right here? Look how huge this is. Look at this coming down. Look how huge this is with this beautiful drawing that I'm doing, okay? Look how huge. Now there's VV ECMO, which is gonna be venous to venous, and what this is basically replacing the lungs. In a simple form, yes, there can be other technicalities on this. This is, if you see, usually it's blue, they'll have blue on there. This is replacing this. Here again, what the purpose of this is to take stress off the lungs. So we'll have a lecture and we'll discuss, and we have a full lecture on ventilators, but also we're gonna have a discussion on ventilators here in our review, is what it does is take stress off the lungs. And by taking stress off the lungs, it allows them to recover. That's all it does. This one is set up in VV ECMO, VA ECMO, excuse me. This is VA ECMO, I apologize right here. VA ECMO. So this is taking stress off the heart. And so this is giving, it's filtering force to the lungs and then also giving support to the heart. This right here is a type of oxygenator. This is where the magic happens, this is where the carbon dioxide is removed and the oxygen is placed. This is just right here, this gives you readings on the oxygenator. This equipment is expensive. This equipment is expensive. See this tubing right here? This tubing roughly, and don't quote me on the prices because prices change. The tubing itself is between $3,000 and $5,000. This oxygenator can be about $5,000 or more dollars, okay? So this is, just this equipment alone is expensive, not talking about the other. That's the variable costs in each patient. The fixed cost of the machines themselves is another story. So it takes a lot of funds to set up an ECMO program. Right here you can see the dramatic difference. Look at the blood difference in here. You can see when it's coming from the oxygenator right here, and this is coming from the oxygenator right here. Here's a good story right here. This is a patient who had COVID-19. They were a first responder. You can see the ECMO placed, the cannula placed. Here they are, is 5 days later, where these lungs have improved. Remember, ECMO is a supporting device for giving the patient time for them to get better, taking stress off the lungs, and we'll learn how the ventilator places stress on the lungs. You can either go to the ventilator lecture or you can follow up in this lecture series on board review, and this will tell you how ventilators can stress the lungs, and this can help take stress off the lungs, take stress off the heart. Remember, it doesn't cure cancer. It doesn't transplant the heart. It doesn't transplant the liver. What it does is it buys time for the body to recover. All right, we're going to do another board review question. Board review question. What is the most appropriate next step in management? We keep getting a lot of these in management right here. So right here is immediate endotracheal intubation, intravenous sodium bicarbonate infusion, whole bowel irrigation. Here we're getting a lot of these very similar, hemodialysis and gastric lavage. Right here, we see this already, 12 hours. Another sad case, this is a 24-year-old woman with depression. The Princeton Emergency Department at 12 hours of ingesting an unknown quantity of aspirin. Aspirin in an attempt to harm herself. She presents with tinnitus, ringing of the ears, nausea, and abdominal pain. She has an elevated temperature, heart rate is elevated, and has an elevated, and the respiratory rate is elevated. Blood pressure is okay right now. Oxygen saturation is okay. Arterial blood gas, look at this, look at this. Look at this, what is that? So normal blood gas, 7.35 to 7.45. We're alkalotic. And this patient is breathing fast and they're trying to blow this off. They're trying to get to the right direction. Okay, they're trying to correct, but they are breathing a little bit too fast. So what do we have here is a respiratory alkalosis. And if we look at it, is the bicarbonate is low with a what? So respiratory alkalosis with a metabolic acidosis. Her serum salicylate levels, let's look at those. Get to erase this all. All right, they're elevated. So therapeutic is, they're 55, they're 10 to 30. What is the next step in management? All right, bicarbonate infusion. That's going to be our next step in management. All right, so let's kind of go through this. Bicarbonate infusion. So this patient right now is, she is alert, so we wouldn't want to intubate. Right now we don't have to intubate. 12 hours after ingestion, this is, we didn't say this is extended or long acting, so how about irrigation? It's probably not going to help. Hemodialysis is reserved for severe toxicity when we have severe end organ dysfunction. We may need to get there. Remember gastric lavage too, within a short time window on there. So what are we doing? We're going to give bicarb. Let's talk about what's going on with salicylate overdose. So what are examples of salicylate? Well, acetoacetic acid, okay? How about bismuth? What's bismuth? It can be a brand name. It's the pink liquid that you can use for GI. How about those pop fizz, those things you pop in there? We won't give the brand name on that, but there is taking these effervescent acids, willow bark, if someone is going to a natural food store, even ginger or mint tea can contain these. All right, so what do we see in this? Is a respiratory alkalosis, the breathing fast, and an anion gap acidosis, tinnitus, okay, which is ringing the ear, agitation and confusion. Bicarbonate infusion, we want to get the urine pH to 7.5 to 8. Our goal, HD if AKI or severe toxicity. We want to alkalize the urine and allow you to pee out the aspirin products. The mainstay of treatment is fluid resuscitation, maintaining euglycemia, using activated charcoal to limit absorption in a certain time window. If we can safely give this to the patient, urine alkalization to enhance renal clearance. And if the concentration is greater than 100 or clinically declining with severe end organ failure, we need hemodialysis. What is this right here? This is a continuous renal replacement machine. These are used in the ICU to go slowly over a period of time. Why do we use these in the ICU versus HG? Because these, their pressures, they're less, they're going to take less blood out of the body all at once, and they have less decreased blood pressure. Because remember, we're fighting for the MAP in the ICU. These blood pressures are usually low on our patients in the ICU. So what are some situations when we would want to do emergent hemodialysis? This can be summarized in the AEIOU. Emergent hemodialysis is going to be A is acidosis, E is electrolytes. Hyperkalemia would be an example. That hyperkalemia that we cannot fix with medical management, just like the acidosis, we cannot fix it with medical management. This is a refractory acidosis that we can fix with CRT and or HD. Ingestion to overdose of certain medications or drugs, overload, fluid or overload, and for whatever reason, like I say in heart failure or the chronic kidney disease or end-stage renal disease, and we have to get this fluid off, and for whatever reason, our diuretic is not working, or uremia, usually start looking at numbers above 100, and which can cause encephalitis and or pericarditis. So the CRT, this happens to be a CRT machine. This takes out of the patient between 150 and 250 milliliters of blood versus hemodialysis can pull out to get through the machine to get activated through the network can be up to 400 to 500 milliliters of blood. So the hemodialysis has a greater chance of lowering blood pressure. All right, now let's talk about a 32-year-old patient with diabetes found with multiple empty pill bottles. We kind of had discussion of this already. This is early on. What can it be? So what's first-line treatment in diabetes currently? Well, SGLT2s are popping up and becoming more and more number one, but guess what's number one still? Metformin. Why is that? Cheap, it works. Cheap and works. All right. Poisons the mitochondria can cause lactic acidosis. I know that there are studies that say it doesn't, but it does. It does, but it doesn't. Here's the labs you want to get. You want to get frequent fingerstick blood glucose, get your ABGs, VBGs, because you want to look at what the acidosis is, chemates, mags, calcium, phos, coags, lactate, beta-hydroxybutyrate, and LFT. You also want to rule out an infection. Treatment is supportive care, glucose management, because guess what? They're going to be hypoglycemic. Fluids, likely you're going to have to give a bicarb drip on these because of the fact that these patients are going to have an acidosis. Methylene blue, remember we talked about this, inhibits the soluble guanine cyclase, which is involved in the production of nitric oxide. This is a potential vasodilator. We're inhibiting the production, increases the vascular tone, and improves blood pressure. All right, now let's talk about a sulfonylurea overdose. Sulfonylureas. Now, should these medications be given to older people? Probably not. Probably not at all, because what happens is, as we get older, our kidney function is good. As we keep saying, guess what? The sulfonylureas are not going to break down as well. You can have significant prolonged hypoglycemia that may occur from therapeutic and super therapeutic administration of sulfonylureas, especially in the setting of renal failure. All right, now let's talk about what the side effects are going to be. As we talked about hypoglycemia, makes sense, right? Confusion, seizures, anxiety, tremors, and diaphoresis. What's the treatment? Giving them sugar, giving them sugar water. Let's get to the red marker. Octreotide. Octreotide helps. We talked about what a workhorse octreotide is. That is a somatostatin analog. It blocks the L-type voltage calcium channel in the pancreatic beta islet cells, inhibits insulin release. Plus glucagon, this equals a temporizing measure. Monitor for hypoglycemia up to 48 hours if large ingestions. All right. Tip, you may want to inquire about recreational drug abuse because glyburide pills have been reported to be sold in the street as Valium, okay? Because they look like Valium. So somebody coming in, they are not diabetic and they don't take sulfonylureas, but they purchased what they thought was Valium on the street. It's going to look like diazepam is the generic. If they purchase diazepam on the street, this may be considered that they're taking glyburide pills. And this can be a glyburide ingestion. So, and this can cause, here again, hypoglycemia, confusion, seizures, anxiety, tremors, and diaphoresis. All right, here we go. Another unfair board question. Which of the following is an important appropriate next step in management? All right, administer datrolene. We haven't talked about that at all. Discontinue all synergetic agents and provide supportive care. What are we looking at right here? Start propranolol, administer bromocriptine, begin emergent hemodialysis. All right, so what do we have here? A 35-year-old woman presents to the emergency department with agitation, diaphoresis, tremor, and confusion. She recently started taking sertraline for depression and was prescribed linezolid for a skin infection. What does the linezolid cover? It's for gram-positives, very similar to vancomycin. You may see places use linezolid where they have trouble with getting labs for vancomycin. This happens. Sometimes they can't get the labs drawn or do not have the proper lab facilities. So instead of worrying about vancomycin toxicity, they use linezolid. And linezolid can cause interactions with the serotonin medications. Your antidepressants. And what's another one that can cause interaction with? It would be fentanyl. On examination, she is febrile, she's hypertensive, tachycardic, she has clonus of the ankles and hyperflexia. So what are we going to do? What do we have here? So what is dantrolene used for? Dantrolene is going to be used for malignant hypothermia, and that is triggered by exposure to certain analgesic agents. So basically they need to be going through a surgery. She hasn't gone through a surgery, and if they're also exposed to muscle relaxant, which would be succinylcholine, she hasn't. Succinylcholine is usually going to be used in intubation. She hasn't been intubated. Bromocriptine, when do you use that? For hyperprolactemias can be used. For acromegaly, not used that much anymore, but can be used. Parkinson's disease and type 2 diabetes. And guess what? There's clinical trials that demonstrated reductions of hemoglobin A1C of 0.6 to 1.2. So this could be a treatment used for diabetes. So what is our answer? Discontinue all serogenic agents and provide supportive care. So what do we have here? We have serotonin syndrome, serotonin toxicity, because the interaction between sertraline and linezolid. Okay, what can we see? Altered mental status, autonomic instability, hypothermia, neuromuscular findings, clonus, hyperflexia, and we'll give an example, a weird example, in case you ever come across this. You need to stop those medications and supportive care. All right, this is one just to kind of think about, and this is a 37-year-old one. This is a real-world example. We did the board question, now we'll go to the real-world example. Depression, altered mental status, and when the patient smiles, they get a weird smile. And you're gonna say, what is the weird smile? This was a severe serotonin toxicity. When this patient smiled, it looked like there were worms underneath their skin because they're getting this myoclonus or clonus of the muscles of the face. And you could literally, when they smiled, it looked like a horror film because you could see the contractions, the little muscles on the face all the way up to reach her forehead. This would be a severe example of a serotonin toxicity. All right, now we're going to talk about SSRI, SSNRI. We have a toxicity. We have agitation, clonus, hyperflexia, rigidity, fever, and tachycardia. What's the treatment? Supportive care, benzodiazepines, and cyproheptadine if severe. Venlafaxine has increased cardiac toxicity. You can see the lower extremity hyperflexia and clonus, mainly lower extremity greater than upper extremity. You can have QTc and QRS prolongation. Overdoses of greater than 8 grams of venlafaxine can cause slow cardiac conduction and risk of ventricular dysrhythmia due to the sodium-potassium channel block. Remember, you can get hypothermia, hyperflexia, clonus. In severe cases, you may need to get ECMO treatment. Remember, ECMO is a bridge. All right, found down in the garage with the car running. So what are we thinking about here? Carbon monoxide intoxication. Smoke inhalation is the leading cause of accidental exposure. Remember, there's a high affinity for hemoglobin binding and will form carboxyhemoglobin, which is ineffective in the transplant of oxygen. You can have tissue hypoxia, can have headaches, confusion, nausea, vomiting, and loss of consciousness can occur. Cardiac ischemia is common among these patients, and they can have delayed cognitive dysfunction, but this can arise months after the exposure. Months after the exposure. Does not lower oxygen saturation on normal pulse oximetry. Co-oximetry, if you happen to have this, it measures the carboxyhemoglobin levels used to make diagnosis. If not, you can pull blood and send it to the lab. Less than 3% is normal, but people who are heavy smokers can have up to 12 and 15%. You remove it by adding oxygen to the hemoglobin. You have 100% oxygen. This is the treatment of choice, and it helps remove the CO2. Hyperbaric oxygen reduces the half-life down of the CO2 down to 30 minutes because the half-life can be long, up to 5 hours. So this will help reduce that by increasing the amount of dissolved oxygen in the blood. Always when you worry about in a patient who's been exposed, say if they're exposed in a fire or smoke inhalation from a fire, you have the possible of cyanide poisoning because a lot of the products in the house, when they catch on fire, these anti-flame resistant products, they can do what? Is it can reduce cyanide poisoning. They have basically a functional anemia. These patients, one-third of these patients, our blood is not able to carry oxygen because you have the CO2, the carbon monoxide in the way. Basically, they need the oxygen. So what will happen is, because the heart is going to take a hit, you're going to have an elevated troponin. It's going to be like, hey, where's my oxygen? And then boom, you're going to have your troponin hit. So you're going to give the 100% oxygen. You do need to run the troponins. They could have a coexisting heart problem. So not only they have carbon monoxide toxicity, but you need to make sure that they're not having a heart attack at the same time. Regular pulse oximetry would be normal. Found down and the patient has no information. This is unfortunately what we see. So found down with no information. Disoriented and obtunded. Pills have been taken 45 minutes prior. So this is where we could consider using what? Activated charcoal product or whole bowel flush. So what are some things that we can give? Naloxone. Well, naloxone is, we're going to look for what? Naloxone is going to be for an opioid toxicity. It hits the mu receptor. It disrupts, it knocks the opioid off the mu receptor and see if we have an improvement. Dextrose, if they take in what? A sulfonylureas. Thiamine, if they haven't induced too much alcohol, and we're trying to avoid Wernicke's encephalopathy. This is the old school way. You can consider giving these right away as kind of a rescue. If no improvement, may need to intubate and use gastric lavage. One is the answer, flumazenol. This is be what? If possible, benzodiazepine. Now, does it cause seizures? Now, it could be, seizures could be an adverse effect of giving flumazenol. The seizures are not the direct result of the flumazenol, but due to the reversal of the anticonvulsant effects of the benzodiazepines. So if they took the benzodiazepines because they have a history of seizures, we're reversing that. And we're going to, the benzodiazepine was sitting in their system on the GABA receptor. We knock that off the GABA receptor and they have an underlying seizure disorder, can precipitate seizures.